Let's start.
Yeah, good afternoon, everyone, and a very warm welcome to this webinar, which is organized by the Indian Academy of Neurology Outreach Service Subsection. As we all know, migraine is one of the leading causes of disability worldwide, and yet it remains largely invisible. It's misunderstood and often, I suppose, trivialized, especially in workplaces. For millions of people, migraine is just not an episodic pain, as all of us know that it affects the productivity, our emotional well-being. Sometimes our career choices also depend. We all know that some of our patients choose certain careers because of these migraine attacks, which can create a problem at their workplace and in turn impairs the quality of life. As neurologists and healthcare professionals, our role does not end with diagnosis and treatment. Advocacy, particularly in the workplace where people spend a large part of their lives, is crucial to reduce the stigma and enable reasonable accommodations and empower individuals who are living with epilepsy. Rightly so, today's session, Neurology Advocacy in the Workplace, the example of migraine, is therefore extremely timely and relevant, especially as we reflect on how global perspectives can inform local outreach efforts in India. It's my greatest pleasure to introduce our distinguished speaker today, Dr. Olivia Begas, a board-certified neurologist and headache specialist from the United States of America, who has been deeply involved in migraine care and advocacy. Dr. Olivia is a board-certified neurologist and headache specialist in Connecticut, USA. She serves on the American Academy of Neurology Brain Health Committee and the International Headache Education Committee. She is a co-chair of the American Headache Society Advocacy Committee. She is a member of the International Commission on Occupational Health and has been active in bringing migraine advocacy to the workplace. She wrote an article on the topic for the Harvard Business Review and has given talks for the American College of Occupational and Environmental Medicine, the Business Group on Health, and the Integrated Benefits Institute, among others. We look forward to learning from her insights and exploring how these principles can be adapted to diverse healthcare and workplace settings, including ours in this country, India. And I also invite all participants to engage actively in this discussion. And we have our Q&A chat box. Kindly put on your questions as and when Dr. Olivia is giving her lecture, what you might feel which is relevant in our settings and how that can be translated. And we hope this session inspires us to take migraine advocacy beyond the clinic and into the real world impact. It's my greatest pleasure again. Thank you for your time on this 2025 year end. And I hope that your talk will enlighten us surely. I know Olivia, she has been an advocate and I have seen her in several conferences, and she's a real hardcore person, real to the core. What she speaks, that she progresses, and that's what we are going to hear today. Welcome, Dr. Olivia, and your lecture, please.
Thank you so much, Dr. Menon. Thank you so much for attending today. It's a great honor and pleasure. And thank you so much for the very kind introduction. I'll try to live up to it. Let's see. So to start about neurology advocacy in the workplace, in the IGAP, in the International Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorder Toolkit, the one neurology subspecialty that the workplace mentioned is actually migraine. And one of the key messages and actions to support people with headache disorders is to provide education, improve diagnosis, and optimize management of headache disorders in the workplace. As a IGAP toolkit published 2 summers ago cites, this will improve health outcome and overall productivity. So why is this such an issue, migraine in the workplace? and we'll talk about the actual impact and possible solutions. So everybody is familiar, but I like to set up the problem because it helps talk and advocate when we talk to employers and people. So migraine is very prevalent, about 14 to 15% global average prevalence, to 114 million people in India. It's also very disabling, one of the leading causes of disability in the world, and therefore global daily for all neurological conditions. Why is migraine so disabling? A lot of people think about the pain, which obviously is disabling. When people were asked to rank the different migraine symptoms in terms of level of disability, pain was first, but cognitive symptoms as second, and often are not really being noticed. 40% of people can have symptoms between migraine attack, and often this includes cognitive symptoms. And then this is followed by nausea, light sensitivity. Then the attacks are unpredictable, which makes people appear or internally feel that they're unreliable at work. Comorbidities too. So depression, anxiety, sleep disturbances are all independently associated with lower productivity, and even increase on the PHQ-9 or GAT-7 scale, even for people who don't necessarily meet the diagnosis for depression or anxiety, is associated with higher migraine-related disability. And as Dr. Menon mentioned, there's a huge emotional impact on the diagnosis and on the management, and wherever different level for different countries, but wherever we are, it's still extremely underdiagnosed and undermanaged, and we know that delay to appropriate diagnosis actually worsen disease, and the stigma, internalized stigma, is independently associated with lower productivity too. And that's the leeway for the stigma. I didn't find a study in India for this, but there were a study of US employers, and 22% of US employers said that migraine is a serious enough condition to warrant work absences. And there's not that it's a fight who has more stigma, but there's a lot of stigma against chronic migraine. And there's been more recently the Overcome study looking at stigma, and about a third of people with migraine experience at least one type of migraine-related stigma, often or very often. So usually it's secondary gain stigma. So people saying that they use migraine or other headache disorder as an excuse to get out of work commitments, or minimizing the disease burden. So they're saying that people exaggerate the symptoms. The stigma also is a barrier to seeking care and getting care. So there is really two main categories of stigma. There's an external stigma that comes from the world around us, colleagues, family, even language, institution, which leads to discrimination, loss of status, loss of relationships, prejudice. And then there's also, over time, people actually internalize the stigma, which can lead to anxiety, guilt, shame regarding one disease, and then presenteeism. So it's going to work and pushing through, but not being productive as they normally would because of the symptoms of the disease. And we have the data showing that people with migraine want to work. It's a common misconception talking with people to advocate for others in the workplace. When the MPP study, when they look at the activities of people with migraine, people are going to stop doing household work, like household chores. Then they're going to stop missing family, they're going to miss family events before they're going to actually miss work, because they prioritize work over every other aspect of their lives. And then, so barriers to care, and the numbers are a little bit different based on the location in the US for the most recent study on this. But 29% of people with headaches consult a healthcare professional, 20% receive an accurate diagnosis, and then 12% receive guideline recommended treatment. There are many barriers to care, but already there's only 12% to get a consultation, accurate diagnosis, appropriate treatment. And then there were another study in Japan that showed that that was a population of employees, not general population, employees at IT company, but 20% of those with headaches, 27% of those with headache sought consultation, and only 2% of them were on preventive treatment. So what is the impact, the personal impact of migraine on productivity? As Dr. Menon mentioned, more than half of people with migraine have to change their career or adapt their career choice because of the disease. In the US, we have only about a third of people with chronic migraine are able to be employed full-time, which obviously has financial repercussions for people. Then migraine is also associated with missed work opportunity, missed additional earning potential for more than a third of people, and it comes with a lot of emotional impact too, of fear of being fired, having to quit the job, guilt, issues with workplace conflicts, and the stress of unpredictability. And this leads to a vicious circle. So migraine, disability, and stigma and lower productivity, it affects career choice, it affects earning potential, and then people have a lower socioeconomic status. Then a lower economic status affects people's ability to be able to seek care and receive adequate care. So the economic impact. So 90% of people with migraine report a negative impact in their overall life. There was a study looking at proportion of moderate to severe disability in all the regions of the world, and it was pretty consistent that about 25% of people with migraine have moderate to severe disability. The estimated annual cost of migraine-related productivity loss to employers is quite challenging because a lot of places do not measure presenteeism, and most of migraine-related productivity loss come from presenteeism. So from just mostly absences, data in the US in 1999 was 13 billion. In Europe, it was 27 billion euros in 2010. Then we had another study in 2008 in the US that estimated that the migraine alone represent 16% of the total US workforce. And then looking at presenteeism in Japan, the estimated cost is about 21 billion of US dollars per year. So the numbers are much higher when actually taking presenteeism into account. The Integrated Benefits Institute, IBI, is a main institute in the US looking at workplace issues affecting productivity, health, and well-being. They did the impact report for migraine in 2018. They are working actually on a newer version that should be published in 2026. but basically from the estimation. And they also actually looked at numbers depending on the industry. And they found that the industry with the lowest migraine-related productivity loss costs is transportation, and then the one with the highest is actually the finance industry. Even from the calculation, which doesn't include everything like early exit from the labor workforce and excess turnover cost. A lot of people, when they leave the workplace, migraine is not, or even neurological conditions are not on the exit interview. Even missing some of the numbers in the calculation, the estimate is about $250,000 per 1,000 employees per year. In terms of presenteeism, so 89% of migraine-related productivity loss is due to presenteeism. It's estimated that people with migraine are 46% effective during a migraine attack. The numbers significantly increase with the increased frequency. The difference between high frequency episodic migraine and chronic migraine may not make too much difference in terms of number of days, and it was an arbitrary number. But even looking at high frequency episodic compared to chronic migraine, we nearly double the numbers of annual days with presenteeism. Why do we care about the impact of migraine on productivity? It affects our entire patient's life, their professional life, and then the socioeconomic, personal, emotional, cognitive, the family relationships. It affects all of us directly or indirectly, because we all know people with migraine, and we can help. And even showing understanding and support and asking patients, how do you cope with your migraine in the workplace, that already helps in and out in itself. If it's such a problem, why do employers don't see it? Because a lot of employers told me, oh, we don't see migraine. There's a lot of stigma, there's a lot of concealment. Most people will not declare to the employer that they have migraine. Presenteeism, we talked about it. Presenteeism is often not measured and it's not seen by the employer. And then there's very minimal healthcare claim cost. Migraine is terribly underdiagnosed and terribly undertreated. Despite that, even in the US, where we have all this CGRP treatment, when you take all, and people do MRI for migraine all the time, when you look at the cost of headache-related treatment for a company, despite all of this expensive stuff, it's less than 1% of the total cost, healthcare cost for the company. And usually employers just pick up the top 5 or top 10 costs and they look at that. But so migraine doesn't get picked up. Okay, so what can we do about it? There's many things we can do about it, but I'm going to talk about the workplace programs because we have actual data on outcomes for this. So workplace migraine education program. So far, there's been 6 published prospective cohort studies. For this, all in the US, we're working on another one also in the US, but that's for global companies. So if it works in the US, hoping we'll expand it to all the branches of that company. When we talk about workplace migraine education, the whole point is to educate the executives, the supervisors, and every single employee in the workplace. We do not want to target people with migraine to tell them to drink more water. That's not helpful. When there was a survey from the Migraine Association of Ireland about what people with migraine want in the workplace, the first thing they said was understanding by their co-workers. And that to help educating everyone is actually making the difference, because oftentimes when you talk to employers, they're like, oh yeah, let's pick up the most costly people and educate them. But that's not how we do things. So that migrant education alone has been shown to increase productivity by 29 to 36%, cut absences by about a quarter, and decrease the number of days work with migraine attack by 32%, and then increase productivity at work during a migraine attack by about 10%, and also decrease stigma by increasing understanding. And it's not an exhaustive list. There have been different migraine education program in the workplaces. I think the main thing though is to make sure that, or the program that you use if you do your program, you make sure that there is actually an intervention for everybody and the outcomes are measured, not doing one little lecture to the occupational health services of the company or human resources and call it a day. Because an education program really happens when you have, it starts from the top, it starts from the leadership buy-in, and then it trickles down, and you need to do touch points and all the communication of the company and really try to integrate the education program within the company. Then workplace migrant education and management program is also 6 prospective code studies so far. I guess they're an equal level right now. There's another one that at least I know of because I'm working on it in the US undergoing this prospective code study. So there's been 2 in the US, 1 in Spain, 1 in Switzerland, 1 in France, and the biggest one to date was in Japan. They've been shown to cut absences by about half, increase productivity at work during a migraine attack by 36 to 59%, and then decrease costs related to decreased productivity. And this program have consistently shown a positive return on investment. It actually doesn't take too much to bring education, help optimize management, compared to the actual burden of migraine on the productivity benefit. So the biggest one to date, published at least in the world, is the Fujitsu headache project. And really, so there were the modules that were created as a collaboration actually with the Japanese Headache Society, the Global Patient Advocacy Coalition for Headache, the International Headache Society. Dr. Humiko Sakai in Japan had actually met with Tarun Dua from the WHO Brain Health Unit, and that actually agreed that one of the priority for migraine advocacy should be the workplace, because most people with migraine are most effective with migraine during the working years of their lives. Most people are underdiagnosed. People don't come to the clinic. So we have to find them where they are. So that had the modules, the teaching modules, and there were also headache seminars, headache consultations for those who wanted, and really trying to address every single aspect of it from the work environment. And it's not just dimmer lights, it's trying to improve understanding, decrease stigma, add some headache exercises, yoga, support. So yeah, so from this talk with Tarun Dua, then they actually had support from the WHO Western Pacific office. The other thing that made it easier with Fujitsu is that they've had prior health promotion programs. They run health promotion programs yearly. The one before migraine was on cancer, so the employees are used to this type of program. Sorry, and they have a very strong occupational health team. This was very successful in terms of participation. 91% of employees participated in the program, and that's out of the 81,000 employees in Japan. Very different from the smaller, actually, population data. They found a 17% migraine prevalence, 70% of employees reported headaches, and 5% moderate to severe headaches. About 4% of employees sought consultation through the program, which I guess is consistent with about the 5% with moderate to severe headache. 91% found the modules useful or very useful. 73% said the modules increase the understanding of headache disorders, and actually the rest said it's because they already understood migraine enough. And 83% without headache said they would change their attitudes towards colleagues with headache disorder as a result of participation in the program. So it really helps with stigma. It increased productivity for those with moderate to severe headache by cutting down on 1.2 days of absences and 14 days of presenteeism per employee per year. This is, yes, MIDAS, so people say we call bias, but I think that's actually helpful to work with a IT company because we actually had good diaries, so people were filling an electronic diary every day, so it's not really recall bias, even if it was using the MIDAS question. And they found a 32-fold positive return on investment, but that's thinking they already had the occupational health team, and it's also IT company. So even if we have the GPAC modules that had to be translated in Japanese and that has to be hosted somewhere, and they could actually host the modules on the internal software. Then it's just that Hartford Healthcare Migraine at Work project. This is a large healthcare organization in the northeast of the US. That alone has taken 3 years to get started. That's how long it takes to convince the leadership. And one of the things to try to understand the extent of the problem is to look at claims-based prevalence. So it's about 33,000 employees, but about 16,000 employees are on the employer health plan. So then you know the actual cost of care for these employees. So that's another data that headache claims actually are less than 1% of the total cost to the employee health plan. Then when we look at the medical cost per member per month and pharmacy cost per member per month of employees with headache compared to without headaches, the people with headaches have higher medical and pharmacy costs than people without headaches. But the difference is not fully explained by the cost of headache claims per se. So there's also comorbidities playing to this, and that may be another reason why the burden is not being picked up. So then for this program, we did a pre-survey, I'll show it to you, of trying to target all employees, but this is the US, so people follow the rules less than in Japan. Then education, so through modules, similar to Japan, and webinars, similar to the seminars. And then we're actually launching the post-survey soon. So that's for the education, and the education has been trying to target every aspect of the company in terms of headache care. So employees interested are being seen by the headache center of the healthcare system. They also get monthly nurse call to make sure things don't fall through the cracks, to make sure they get the medicines, they know how to use it, they understand the plan. Then they do electronic diary, and there's also support groups. So right now, so there's about 33,000 employees. despite our best efforts on talking with the communication team, they say usually there's about 20,000 employees that can actually be reached, that open their email, look at the internal server. So that's as best as they can do. About a third agreed to participate, and 29% completed the survey, which looked much worse than Japan, but considering they have an average 10% click rate for the employee communication, so that's actually much better than the average click rate. There we found that 93% of people who answered, so obviously the selection bias, had headaches, and about 60% screen positive for migraine. For those who screen positive for migraine, they missed on average 0.66 work days every 3 months, and 3.8 days basically of reduced productivity by at least 50%. So the estimated lost productive time is about 10 days annually per year for people with migraine, which is actually much higher than the estimated lost productive time for those with non-migraine headache, that is less than 1 day per year. And even if we took only those who answered the survey, that over the total number of 33,000 employees, the prevalence would be at basically 9.3%. So that's still higher than appears in people who get care for the migraine. And to get there, takes time to publish and actually get outcomes in workplace education program. But in terms of outreach, it takes a long time to actually convince employers that this is a problem. I've been given talk, for example, at the ACOMS, American College of Occupational and Environmental Medicine, at the Integrative Benefit Institute, the Business Group of Health, the other occupational health conferences, ICO, and companies close by, like for example, BIC, the pen company, the factory close by. So it asked them if I can go talk and see the employees, then the radio too. So it's really trying to find any way that we can actually raise a conversation and talk the language of employers. So talk about productivity. So migraine is a leading and hidden cause of decreased productivity. There are things we can do. And one of the main things is communication, raising awareness, bringing education, using non-stigmatizing language. And then we have some model of workplace intervention. It's really, can we expand of this workplace intervention to other countries of the world, and hopefully India, and then maybe add brain health and other neurological conditions. I'm happy to answer any questions.
Thank you. Thank you so much, Olivia, for this
Yeah, my pleasure.
Yeah, for that run through of all the studies as well, which does tell us that migraine does not fit into the traditional image of a disability in the workplace. We get so many patients. I also feel it's because the symptoms keep fluctuating and they're unpredictable, and the outward signs are so minimal until unless the person does look so agonizing in pain. That leads to a misunderstanding. We have a question here from Dr. Gautam Kumar Saha. He is a senior scientist at the Apollo Hospital Educational and Research Foundation. His question is, do you have any defined biomarkers, both imaging and blood biomarkers for migraine? And which groups are working on the diagnostic and prognostic markers?
Yeah, in clinical practice, we don't. Unfortunately, there's different groups based on the actual approaches. I know the group with Jajat Torin and Irene de Boer Like there's a group in Holland with a lot of people working on genetics. There's another group at Harvard MGH working on genetics. There is a group of Dr. Catherine Chan and Tom Shred looking on imaging. There are a lot of different people working on different biomarkers, but in clinical practice, we don't. And in terms of migraine in the workplace outreach, I don't even think sometimes the problem is actually very basic. It's the stigma and the lack of recognition, because oftentimes it's actually very clear that people have migraine. When people talk about biomarkers, I think another thing would be to have good studies of migraine presentations in different populations. Because a lot of the migraine criteria were mostly made for white European middle-aged people, mostly women. Then when we go to different regions of the world, we can get different complaints and symptoms from patients. So it would actually be good to take a look at that too.
Yes. So it's predominantly a clinical diagnosis and it still continues to remain so. Some sort of imaging biomarkers might be there. We do see some teeny spots in the MRI, which does look like migraine vasculitis. So do you think, Olivia, that as the patient's migraine progresses, the number of these white spots in the brain, could they be suggestive of increasing burden of migraine? And do these patients are at more risk of developing stroke in the later part of their life rather than the ones which who are not?
No, so the migraine related white matter changes do not correlate with migraine burden directly and are not predictive. There's been actually studies too. They look different from the actual microvascular changes, and they are not associated. The migraine-related white matter changes are not associated with stroke or actually cognitive decline and risk of Alzheimer's disease. So we actually think it's a different pathway in terms of stroke. People with migraine with aura and stroke, it's not through the white matter changes. Migraine right now is a terribly clinical diagnosis. If we do MRIs to rule out secondary causes, or in the US, there's people who also do it because they don't know and they don't want a lawsuit later. So the MRI, but there's not a real clinical reason to do MRI. And I was talking about the diagnosis in different populations because, for example, even it's thought to be a woman disease, which also doesn't help with the stigma and recognition. Even in the US, I have men who apologize for being in my clinic. And at Fujitsu, there were 17% migraine prevalence, with more than 80% of employees being men. So there is and a lot of men that don't complain of nausea, they complain of anorexia. So it's how do we actually can listen and diagnose people who may not have the typical migraine presentation.
Absolutely. And we know that there has to be some reasonable workplace accommodations, Olivia. So in all of your studies, what have you felt that what are some simple evidence-based workplace? Obviously, it differs from one place to the other, but one which would cater to all as an umbrella, evidence-based workplace accommodations that can
Yeah.
have meaningful difference.
Yeah, but there's not good studies on accommodation and the difference, but there are studies on factors that are most associated with migraine-related disability. So then you can assume that if you target those factors, you would have the mean difference, but there's no studies that I know of looking that show this workplace accommodation needs to this level. Except there's a few studies, but the N was very small of night shift. So changing schedule. I mean, you know this also with epilepsy,
Yeah.
but that's
Yes.
pretty terrible for people. But people always think about, and it's true, environment of light, temperature, heat, noise, smell. Yes, that's a
Yeah.
factor. But also level of physical activity, level of autonomy. People with less autonomy and on lower level jobs have more migraine-related disability than people with more autonomy. And another factor is support and understanding from the team and supervisor. So there is that can be done in terms of trying to change the atmosphere of the environment to make it less stressful because you don't need to the workload is there, but there's a lot of unnecessary stress sometimes in workplaces. But in general, some of the basics is access to water, access to restrooms, so they can actually drink water,
Yeah.
temperature control.
Yeah.
If we already did that, and then posture, right? I had met someone in Peru who works for a leather factory in Peru, and all of her workers are bending their head down. And she said, I have 1% prevalence of headache. Like, maybe you need to do something about the posture of your workers. Yeah, that's another big one for some.
Yes, yes, absolutely. So we do find certain professions do tend to trigger off like continuous bend postures, which triggers of the cervicogenic area, we see it as a trigger, and then we know that yes, it leads to them. We have another question from Professor Jack Race, who has done extensive work in environmental neurology and is connected to the World Federation. He types his answer from France. Is working a migraine trigger in some companies? Did you observe in your practice differences regarding the patient's job, which is a position in the company, and the type of workplace?
Yeah, so definitely the job position, in the studies, it's attributed to a sense of autonomy. So the job position matters, and it's probably with lower position being a state with less productivity. And that's pre-autonomy, but also ability to probably have a more flexible schedule and less fear about being fired. Type of workplaces too, but then sometimes it's hard to get numbers too, because for example, in the IBI so far, construction, transportation were less affected in the numbers that finance, but it does raise a question because these people are exposed to so many triggers. Is that because it's underreported? Because this is usually men and there is more stigma that do tough jobs. Or do they also have less access to care, so it's less diagnosed? I never mention and triggers too. So the idea of trigger, a lot of people now try to be careful with the notion of trigger because a lot of migraine related triggers like people say chocolate, but it's mostly food craving. So we think that migraines start with a hypothalamic activation that can lead to food cravings, increased appetite. And some people think that, oh, this is a trigger, but this is actually the first phase of the migraine attack. So we have in the past placed more importance in triggers that they actually really is triggers. I do believe that work is part of health, and people with migraine who stop working, the migraine get much worse because they feel like a burden to society. They feel intense guilt. They're grieving their work, not working. There's some extreme cases, but for most people, it's not working, it's finding a job or adjusting the job so they can work because not working often actually is not the solution. So, and sometimes it can be so simple. Like recently, I saw a pharmacist that was in the compound area of the pharmacy and she had daily severe migraine because of the smell of all the chemicals. And then they moved her to the patient facing pharmacist, which should not I would have expected it's not that much better, but she got so much better because there were less smells. Still working the same job in for the same employer with the same salary. And it takes time, right? As a doctor, it's hard to do that. Some people also use case managers, case workers, but it makes a huge difference in patients' lives.
Yes, true, Olivia. What you just mentioned, I have a student here from the neuroscience department who also vouches for that this health affecting concern to be considered. This is Shravya. Daily life products like shampoos, soaps, gels, certain beverages, and especially a modern food habitat, and even the microphones, computers, which is playing a key role in future kids showing a potential impact. Is there something to be worked on? I suppose yes, and you may want to throw a light on that. Yeah.
There's some that are hard, some that are easier, right? For the screens, for example, even in the workplace, I tell people put them on night mode. If you can put a blue light screen filter, we move oftentimes. Oftentimes, I write letters for my patients for them to be moved to areas of natural light so they're not sitting, the one sitting under the fluorescent light. Caps is usually not helpful because then you press on the trigeminal nerve branches. So some are easier in lots of countries of the world, like people buy food and shampoo that they can afford. So that's a little bit, I think, one of the easiest to deal with is screens and lights. But yeah, and it's a lot of it is brain health, right? A lot of things we do for migraine prevention is brain health. So that's another thing I think another low-hanging fruit for workplace program would be to bring brain health advocacy in the workplace.
Absolutely. I suppose, and Olivia, do you think that there is a role of integrating migraine into the occupational health policy, the national NCD programs? Because we know that the burden is very huge. And also, I just wanted to know all of those workplace studies which you did you find that there is any change in the reporting tendency of migraine among women? Did women report it less, depending on the stigma, which does happen in a country like mine? Usually, also because if they report in a healthcare facility that they're having migraines and they're grieving with migraine, then there's a small doubt of fear of the loss of job, because I'm not sure how blinded it is in a workplace. You might tend to disclose it that 15-20% are having. So did you find any of this, and how do you feel that integrating into NCD programs, given the eye gap and that we have, so that workplace wellness initiatives can be initiated, especially in a country like mine where workforce is the most important drawback sometimes we have in certain sectors?
Yeah, I think it has to be integrated. That's a huge burden to people, a huge issue. And the solution is actually not that difficult when you think about it, to provide education and basic migraine treatment optimization is not difficult either. So that's easy to do with a huge productivity return if we have to terms in terms of productivity for the employers, because we obviously want patients to be able to live their lives talking the language. Um, in your question is hard because oftentimes it's not reported. Sometimes it's reported but not stored. So, for example, even the one of the company I worked for the disability request, that even if they say migraine, then they only store the data as brain issue. So we
Yeah.
don't have much data on the report to the employer, but part of why it takes so long to set up migrant education management program with actually collection of data is that we have to go through all of that because people don't want to report to the employers, right? So it's setting up projects, so it's all by third party, it's all anonymous, and it's talking with legal, it's talking with the ethical committee if there is one. it's a whole process to set it up, to actually have people fill these surveys and fill them honestly, because the report to the employee, some of the US and in Japan too, right? It was the same thing. We didn't have any report directly to the company. And also a lot of our data so far has been in a predominantly male population, so that doesn't actually help
Yeah,
with the woman. But yeah, we definitely don't have much actual reported data because of all these employee considerations. People want to protect their jobs. Yeah.
yeah. It really becomes difficult, and what a commendable work you have done for advocating neurology advocacy in the workplace. Yeah. So I see there are no more questions in the chat box. So as we conclude this enriching session, I believe that all of you do appreciate that how powerfully today's discussion has highlighted that migraine is not just a neurological condition, but a workplace and a societal issue that demands advocacy. And Dr. Olivia has beautifully demonstrated how a neurologist can extend their impact far beyond a consulting room. So all of us do treat, put medications and then send them off, but then engaging into within the workplace, shaping conversations around the accommodation to the best possible manner. There are restrictions from both sides, and advocating policies that could be. On behalf of the Indian Academy of Neurology Outreach Subsection, I sincerely thank Dr. Olivia for sharing her time, experience, and insights with us today. And I think this is an eye-opener, Olivia. All of us are trying to look into this, and I definitely would try to preach and propagate what you have done so far into my workplace as well. Thank you for sharing your time and experience and insight. Grateful for your commitment as well for advocating migraine care and advocacy globally, which puts migraine at a pedestal which needs and demands the attention. Thanking all the participants as well. Is there a chat, something in the chat? No, yeah, everybody's thanking. So let us carry forward the lessons from today. Wishing everybody a happy new year 2026. Indian Academy of Neurology will come out with more of such great speakers who would enlighten us with their talk. Thank you very much again, Olivia, for your gracious
Yeah,
presence
thank
here.
you so much. Thank you so much for having me. Thank you everyone for attending. And you can always email me, contact me if you have questions or you're trying to set it up in your workplace. Yeah.
Thank you very much. Thank you.
Thank you. Bye.